All right. All right, Dr. Shaw, we can start with the call to order.
All right. Thank you, Amanda. So I will go ahead and call the November 3rd, 2023 meeting of the Therapeutics Committee meeting to order. I guess as chair, I'll take the short prerogative and acknowledge Dr. Sullivan's period of service on the committee. He's moved on to, I think, a new endeavor with the state of Indiana. So that is a wonderful addition there, but our loss. So we will look forward to a new T committee member in the future. So I will turn the mic over to OMPP.
Morning, everybody. I was just going to reiterate Dr. Sullivan is now medical director for Medicaid. He started, I think he's in his first month and he is learning quickly. So we do have a vacancy. It is a physician vacancy. So if anybody knows anyone, send them my way. This one is not, this committee is not governor appointed. It's appointed by the DUR board. So that's a little bit easier, a little bit quicker process. So if you know anyone that is interested, we are happy to discuss. And I think that's all that OMPP has today. Welcome. Thank you.
All right, so the next up is the approval of the memoranda from the meeting in August.
Yes. So we have the memoranda from Optum. It's been distributed to members of the committee. Is there a motion to approve?
So moved.
Is there a second?
Second. This is Zach.
Thank you. Thank you. Are there any edits or comments regarding the memoranda? All right, hearing none. All in favor? I guess we have to do a roll call.
I will start with you.
Yes.
Dr. Shaw.
Aye.
Dr. Marshall.
Aye.
Mr. Musial.
Aye.
Dr. Negendink.
Aye.
And Dr. Weber.
Aye.
And do we have Dr. Patel yet by chance? Just so I'm not skipping you in a vote. All right, I don't hear him yet. All right, so looks like we have all ayes, so that motion will carry. All right, we will go up to our review then. Oh, let me not move quite that fast. All right, in the CNS and others classes, we have no recommended changes in the gastroprotective agents. For the agents for the treatment of opiate addiction, we have recommendations on Brixadi to maintain its current status, which is non-preferred, and then to add it to the agents for treatment of opioid use disorder PA with drug-specific PA criteria and maintaining its current age limit. And then we would have the following quantity limits. So for the weekly doses, they would not exceed one of the following. So for the 8, 16, 24, and 32, they're at 1 injection per 6 days. And then for the monthly dose, they would not exceed either 1 injection per 28 days of the 64, 96, or 128. For OPV, which is a nalmefene nasal spray, we're recommending adding that to preferred. And then Sublocade, we're recommending moving to preferred and adding to the agents for the treatment of opioid use disorder PA with drug-specific PA criteria and maintaining its current quantity and age limits. For the antiemetic, anti-vertigo agents, but we're doing a switch between Bonjesta and Diclegis. So Bonjesta would move to non-preferred, maintaining its current quantity limit, and then adding a max quantity limit of 270 days of therapy per 365. And then Diclegis would just move to the preferred and be on the preferred brand drug list. So this would be for the brand and not the generic. And then maintaining its current quantity limit and then adding the max of the 270 days of therapy per 365. For the anti-seizure agents, the brand Solantin, we're going to add to preferred brand drug list. That'll be effective on 12/1/23 since we'll be just flip-flopping the brand and the generic. The methoxamide is going to non-preferred with PA around meeting the generic medically necessary criteria. And then Motpoly XR, which is a extended release lacosamide product, we're recommending adding to non-preferred. The immediate release lacosamide is still in the preferred so that they can access that. In the movement disorder agents, Austedo XR tablets and the Austedo XR titration kit, we're recommending moving to preferred and updating the PA criteria to remove the rationale for use of Austedo XR over the Austedo immediate release. We're trying to make sure we capture all the agents in this class, especially around the SUPDL or the single PDL. So we're adding the benztropine tablet and injection and the trihexyphenidyl tablet and solution to this class. Both of them will be added to preferred. And then Ingrezza, maintaining its current status, but updating its PA criteria to include a diagnosis of chorea associated with Huntington's disease with an age limit of 18 years of age and older, a max dose of 80 milligrams per day, and then a max of 1 capsule per day on each of their capsule strengths, the 40, 60, and 80. For the narcotic antitussives and combinations, we did make some recommendations around the PA for the narcotics antitussives, just to make that a little more clear on what we're trying to do with the opiate PA. So they were following some opiate PA criteria that didn't fully necessarily make sense with narcotic antitussives. So historically, the PA was current utilizers of narcotic therapy for 90 of 120, but we don't necessarily want somebody who's been using just hydrocodone tablets for 90 of 120 to all of a sudden be able to use kind of unlimited narcotic antitussives as well. So we changed that to narcotic antitussive therapy, basically if they've used that long term. We removed sickle cell disease as an exclusionary diagnosis, as we don't feel like you would need a narcotic antitussive for the treatment of sickle cell. We're updating the terminal diagnosis to other terminal diagnosis with concomitant intractable cough, since we know that does happen in some patients, especially end-of-life COPD. And then we would maintain the cancer and palliative care as an exclusionary diagnosis. So just kind of clarifying some of that criteria around the narcotic antitussives. For the hydrocodone hematropine tablets, we would maintain its current status and current age limit, but add a quantity limit of 36 tablets per prescription. And then for the promethazine BC codeine syrup, maintaining its age and status, but adding a quantity limit of 6 ounces per prescription. And this is just so we can have quantity limits on every single product in the narcotic antitussive so that it's consistent across the board. All right, in the narcotics, again, adding some other agents that historically haven't been on the PDL, but wanting to make sure we capture everything. So you'll see a few kind of oldies on here that we're bringing on. First one, belladonna and opium suppositories, recommending adding this to non-preferred and in the non-preferred short-acting PA criteria, and to the short-acting look back for duplicate opioid therapy. Lortab elixir is no longer manufactured in CMS terms, so we're recommending removing that from the SUPDL. Methadone, we wanted to put a note in that methadone for opioid use disorder is not permissible for reimbursement through the pharmacy benefit, just to try and make that as clear as we can that they need to go and use the medical benefit for that treatment. And then for the methadone concentrated solution, maintaining its current status, but adding quantity limits of 6 mLs per day or 12 mLs per day for the exclusionary diagnoses. And then for the methadone 10 milligram tablets and 10 milligram per 5 ml solution, maintaining its current status and updating its quantity limits of the 10 per 5 milligram solution to quantity limit of 60 mLs per day, and then the tabs to 12 tabs per day. This is trying to help us be consistent with the current CDC update. And more narcotics. So the opium tincture, another oldie, adding to preferred, and the preferred short-acting Silenoth PA criteria, and that look back. Oxycodone, ibuprofen is no longer manufactured in CMS terms, so recommending removing that from the SUPDL. Qdolo is no longer participating in the MDRP, so we're removing that from the SUPDL. And then Siglentis, we're recommending adding a quantity limit of 4 tablets per day. And then for tramadol products, except for the tramadol ER and the tapentadol products, except for the ER products, we're maintaining its current status, but updating quantity limits for the new and short-term utilizers to ensure that the quantity limits don't exceed the 60 morphine milligram equivalent, and then maintain the same quantity limits that we have currently established for the long-term utilizers. And again, this is around the CDC update for some of the MME conversion factors. In the skeletal muscle relaxants, orphenadrine, aspirin, caffeine, recommending adding to non-preferred. In the smoking deterrent agents, the brand Chantix is no longer manufactured in CMS terms, so recommending removing that, but the generic varenicline is still available, so that will still be on the PDL. The Nica Relief nicotine gum we're recommending removing because they are no longer participating in the MDRP. And then for the non-preferred nicotine replacement products, we wanted to be consistent with the preferred and have an age and quantity limit for those agents as well. So we've added the age of 10 years and older across the Nicotrol inhaler and the Nicotrol NS. And then for the Nicotrol NS, a quantity limit of 12 bottles per 30 days. And the Nicotrol inhaler, 3 inhalers per 31 days. And that concludes the CNS and others, which was a lot. Any questions before we move on to dermatologic? Alrighty. No recommended changes in the anti-psoriatics class. For the acne agents, Azilex, we're recommending removing from the PDL as they are no longer participating in the MDRP. Benzapro Short Contact and Benzeq Wash, recommending removing from the SGPDL as they are no longer manufactured and CMS termed. And then several other products that we're removing because they are no longer manufactured, the BP Cream, the BP Pads, the RE Wash, and the Sebprev Wash. Just a little cleanup in the acne agents since you see a lot of removals here. Again, 3 additional agents that are no longer manufactured in CMS term, the Prassion Cleanser, Prassion FC Cleanser, and the Prassion RA Cream. And that concludes the dermatologic agents. For the endocrine recommendations, we have no recommended changes in the classes listed here. For the bone resorption inhibitors, on the alendronate, 70 milligrams per 75 mLs, you'll notice this in a few things that we're bringing in. You might remember from our last meeting where we were updating the age limit to 12 years for being unable to swallow tablets or capsules. So that's basically what we've done here as well, that they must be 5 years of age or older or less than 12 years of age or unable to swallow tablets. The etidronate, we're recommending removing from the SUPDL as it's no longer manufactured and CMS termed. For the DPP-4 inhibitors and combination agents, saxagliptin moving to non-preferred and the saxagliptin metformin ER moved to non-preferred. For the GLP-1 receptor agonists and combinations, the Adalimumab we're removing from the SUPDL as it's no longer manufactured and CMS termed, and then we made some updates to the criteria. So for the Vidurion, B-Size, Mounjaro, and Rybelsus, we're maintaining their current status as non-preferred, but updating the initial and reauthorization PA criteria, which is going to be looking for a trial and failure of at least 2 preferred agents for 90 days each, one of which is Ozempic or Trulicity. So one of our preferred, one of the kind of higher efficacy agents or medical justification for use. This will be on the initial and the reauthorization just to validate that they've had that before, since we have had patients that have started on other therapy without trialing a preferred agent prior. And then for Byetta, Ozempic, Trulicity, and Victoza, maintaining its current status, but updating the initial PA criteria to clarify the requirements for the metformin trial and failure. For growth hormones, for the somatropin agents, we're maintaining its current status, but updating the initial authorization and reauthorization criteria for adult members or members with closed epiphyses, that they have a prescriber attestation that they are continuing to monitor the member for intracranial lesion or tumor recurrence, progression of underlying disease, or malignant transformation of skin lesions, if appropriate. And then Ngenla, which is a new extended release product, we're recommending adding to non-preferred with drug-specific PA criteria and an age limit of 3 years of age and older, and they will have a trial and failure history of Skytrofa, which is another longer-acting product. For Nutropin, we're recommending removing from the SUPDL as they are no longer manufactured in CMS term, but the Nutropin AQ is, so that will still be available. For Sogroyo, we're recommending maintaining its current status, updating its PA criteria to allow for use in members 2.5 years of age and older, and then adding that trial and failure of Skytrofa. And then Skytrofa is moving to preferred and updating its step therapy requirement to a trial and failure of 1 short-acting somatropin product. So basically you'll have 1 short-acting product, then you could go to Skytrofa, and then if you've trialed Skytrofa and failed, you could go to Sogroyo or the Ngenla. All right. In the insulins, rapid acting, recommending moving insulin aspart, all formulations to preferred, and then the Novolog, all formulations to non-preferred, so switching those. In the insulin's long-acting, the insulin degludec, flex, and vials, moving to preferred with step therapy of a trial and failure of Lantus or Levemir for 90 of the past 120 days, which is the current step therapy that's on Tresiba. And we're basically flipping this with Tresiba, so Tresiba would then move to non-preferred and just have regular non-preferred criteria without the step therapy. And then the insulin glargine, the Winthrop brand that we currently had listed as preferred, that would move to non-preferred. In the miscellaneous oral anti-diabetic agents, the metformin solution, updating its step therapy around the 12 years of age for swallowing tablets. So this would be, must be 10 years of age or older and less than 12 years of age or unable to swallow tablets. In the SGLT2 inhibitors and combinations, we now have SGLT1 inhibitors, so we can't really just call it SGLT2. So we'd like to rename this class to just SGLT inhibitors and combinations to capture all the products. And then for the Brenzavi, we recommend adding that to non-preferred, and then the Inpefa adding to non-preferred. In the testosterones, the Androgel 1.62% metered pump gel no longer participates in the MDRP. They switched to a new manufacturer and they are not participating, so we have to remove that from the SUPDL. And then we wanted to add some quantity limits to some of the oral agents that we historically did not have quantity limits on. So for Jatenzo, maintaining its current status and PA criteria, but adding quantity limits. So for the 158 milligrams, it's 2 capsules per day. The 198 milligram strength is 4 capsules per day, and the 237 milligram strength is 2 capsules per day. Kysotrex is also no longer participating in the MDRP, so we have removed that from the SUPDL and removed it from the PA criteria. So that's just kind of an update since we've already done that one. For METHI-test, maintaining its current status and PA criteria and adding a quantity limit for the breast cancer indication of 50 capsules or tablets per day, and all other indications is 5 capsules or tablets per day. The oxandrin is no longer an FDA-approved drug, so we need to remove that from the SUPDL. And then T-Lando, maintaining its current status, but adding a quantity limit of 4 capsules per day. And then lastly, on the preferred injectable and topical testosterone agents, we want to update the reauthorization criteria to allow use of either topical or injectable testosterone for at least 90 of 120 days to be able to get to that reauthorization criteria. So if somebody was using the topical and needed to switch to the injectable, they should be able to do that, and vice versa if they were on the injectable and needed to switch to the topical. So we just wanted to clarify that in the PA criteria. And we are recommending adding a new drug class to the endocrine category, the urea cycle disorders. So that's what we would title the class. And then with these new products, we would have Bufenil powder and tablets adding to preferred and adding to the preferred brand drug list with drug-specific PA. Carbaglu would also go to preferred and maintain brand preference. We already have brand preference on it today, and adding drug-specific PA criteria. Feburane would go to preferred with drug-specific PA criteria, and then carglumic acid, Alpruva, Reviti, and sodium phenylbutyrate powder and tablets would all go to non-preferred with drug-specific PA criteria.
So for urea cycle disorders, you're going to encompass gout?
Let me look in our criteria. I can't. Sorry, I've got a lot of criteria printed out, so just give me a second. Here it is. I think it's more, so we're looking more for,
We're looking more for
Like-
urea cycle disorders.
yeah, like enzymatic deficiencies.
Yeah. I understand, but I think most people looking at it would probably think gout.
So you think we should, what would your recommendation be? Like including gout here or renaming it something different, or what are your thoughts on that? Or urea cycle disorders excluding gout? Because I don't think.
Honestly, I think the agents to treat gout specifically would all be preferred anyway. So
Right.
that may be the easiest way, just to sort of add it as.
Put a note in that it's not including agents for gout,
Or just
add them all in.
add all gout
I'm
agents.
trying to think, do we have any of them captured? Like colchicine and everything separate, and allopurinol, we don't have captured in OPID, right?
No, those are all neutral.
Okay, so we can, if you would like us to, and we can do that when we get to the recommendations point, we could take that back as a recommendation just to evaluate them and then add them in as well to make sure there's no issue. They're all neutral and open right now, so everybody can access them, but
Right.
we can make sure that we capture them so it's not, so as to not confuse. And we might need to talk about that in the second session if that's going to be a concern, adding additional agents. Okay. Very fair, thank you. We'll take that back. Any other questions in the endocrine or for urea cycle in specific? All right. And the estrogen and related agents, Veoza, we're recommending adding to non-preferred with drug-specific PA criteria, an age limit of 18 years of age or older, and a quantity limit of 1 tablet per day. In the contraceptives, we are recommending that Twirla be maintained as preferred as well as Xulane, and then Zafemy move to non-preferred. Everything else, all other contraceptives would be preferred still. And that concludes the estrogen and related agents. For the gastrointestinal agents, we have no recommended changes in the classes listed here. For the anti-ulcer agents, for the Carafate suspension, again, updating the age around the 12 years of age. So we've got must be 1 year of age or older or less than 12 or unable to swallow the tablets. For the H2 receptor antagonist, the same thing for the famotidine oral suspension. So updating that they must be under 12 years of age or unable to swallow the tablets. For the laxatives and cathartics, we historically have not had the Relistor injection, which is a sub-Q injection on the PDL, so recommending adding that to preferred. With step therapy, it requires trial of lactulose sorbitol or polyethylene glycol and a diagnosis of opioid-induced constipation. And then in the proton pump inhibitors, the esomeprazole strontium is no longer manufactured in CMS terms, so recommending removing that. And then the ribeprazole sprinkle capsules, we've removed from the SUPDL because they're no longer participating in the MDRP. And that concludes the gastrointestinal agents. For the genital urinary agents, we have no recommended changes in BPH. For the urinary tract antispasmodic anti-incontinence agents, again, updating around the age for being able to swallow tablets or capsules. So for the Myrbetriq granules, updating the age to must be 3 years of age or older, or less than 12, or unable to swallow the tablets. And then for the Vesicare LS, updating the age to must be 2 years of age and older, and less than 12 years of age, or unable to swallow the tablets. And that concludes the GU agents. For the hematologic agents, we have no recommended changes in the platelet aggregation inhibitors. For the direct oral anticoagulants, for the Xarelto suspension, again, updating around the age, so must be under 12 years of age or unable to swallow the tablets. For the hematinics, Jesdrubrac, we're recommending adding to non-preferred with drug-specific PA criteria and an age limit of 18 years of age and older, and then a max dose of 24 milligrams per day. And then you can see the quantity limits there for strength. So for the 1, 2, and 4, it's at 1 tablet per day. And then for the 6, it's at 2 tablets per day, and the 8 at 3. And then Reblozyl, maintaining its current status and updating its drug-specific PA criteria to remove the previous erythropoiesis stimulating agent step therapy requirements for myelodysplastic syndrome indication and adding continuation of therapy criteria. For the leukocyte stimulants, we are recommending that Fulphila move to non-preferred and then Nivepria move to preferred. So switching those two, we would love to just have Philnetra still having some stock issues. It is available on the market now, but it's very low stock still. So we want to make sure that we're capturing an additional product or additional biosimilar there, just to make sure we're okay with stock. And then Nivastem, we're recommending moving to non-preferred and then switching back to the originator Neupogen to preferred. And that concludes the hematologic. Do we have a question, or was that just somebody who didn't have their mic muted? All right, we'll continue. In the topical agents, we have no recommended changes in the classes listed here. For the dry eye disease, Isuvis, we're maintaining its current status and updating its quantity limit that it does not exceed 2 bottles for a maximum of 14 days at a time and limited to 1 fill every 90 days. And then we have a new product. I'm going to call it Mibo because I think having I in it makes it just that much more fun. And that it's being added to non-preferred and drug-specific PA criteria with a quantity limit of 4 bottles per 30 days. So if it's Mibo and you're the manufacturer, you should have named it Mibo, and hopefully it is. And also for the Miotics intraocular pressure reducers, IUZA, we're recommending adding to non-preferred, and following step therapy, it must have trialed and failed latanoprost, or prescriber has provided medical justification for use. In the topical antiparasitics, we're doing kind of another switch here with Natroba and Spinosad. So Natroba would move to preferred and maintain its current quantity limit, and Spinosad would move to non-preferred and maintain its current quantity limit. In the topical immunomodulators, Zoryve, we're maintaining current status and current trial and failure history, but updating the age limit to allow for use in 6 years of age and older. And then lastly, if you remember at our last review of the targeted immunomodulators, there were a lot of new biosimilars for adalimumab, and we wanted to bring that back for an off-cycle review so that we could capture those products when they had had a time to kind of assess their pricing and see where everything was going to lie. So our current recommendations as of now are to have adalimumab, the Mylan brand, move to preferred and move to the preferred Silenoff PA criteria, as well as Hadlima move to preferred and move to the preferred Silenoff PA criteria. The other biosimilars would continue in non-preferred, and then Humira would continue to be preferred. So there'd be 3, Humira, Hadlima, and then the Mylan adalimumab brand. Any questions on any thing that we've gone over so far?
So if I can ask about the narcotic class.
Mm-hmm.
So I do see that the recommendation to move tincture of opium to, or inclusion of tincture of opium.
Yes.
And it'd be added under short-acting opioid therapy,
Mm-hmm.
under the PA process.
Mm-hmm.
So I'm just sort of thinking that one of my clinic patients has pretty severe Crohn's. GI is providing him tincture of opium to manage the chronic diarrhea. And then he also has chronic back pain, for which I give him hydrocodone, acetaminophen. That would require a call to the call center.
Has he been on it for longer than 90 of the past 120 days?
Yes, I mean, he's been on this for years.
Then no, it would not require a call to the call center today. It would only be for a new.
Amanda, sorry.
Huh?
Is he short-acting hydrocodone?
Yeah, yes.
Oh, then yes, he
Yeah,
would
so it
require
would
a call
trigger
center
for 2.
today, sorry. Because if it would be
Could
two
trigger
separate
two.
agents.
Okay. I'm just trying to think through the recommendation. Okay.
If he were on a long-acting opioid product that he'd been on for 90 of 120, then no, they could be on two, like a long-acting and a short-acting.
Okay. So that concludes Optum's review.
That should take us up to new business then.
Yes. And I
Any
don't,
new business before I go through mine? Avert your eyes if you're looking at the screen. I don't want to give anybody a seizure right now. All right, I'm hearing no other new business, so we just wanted to go over our opioid data for you all, so you have that. We'd go over this with the DUR board as well. So for the reporting for September, we did increase our total opioid utilizers a little bit from August, but we did decrease our new opioid utilizers. And since if you have been following along with DUR board, you would know this, but if not, we did have quite a bit of an increase in new utilizers in the August, kind of July period. So we saw that kind of go down or back down a little bit. And you'll see in the graph when we get in the next grouping that we have been kind of increasing over time, and we can talk a little bit about that here in just a second. Our under 18 years of age is holding fairly steady in around 5 days for an average day supply. You can see the breakout between the less than 90, which is where the vast majority of our patients are at, and to the ones above that, and then those that are PA exempt. And I'll go through, I think it's easier to see in graphical format kind of what that means. So here's those patients that are above 90. So again, the vast majority of our patients are in the less than 90. We do have 90 to 120 and then kind of a smattering there throughout, and you can see kind of them in the decrease. You will notice that we kind of have a little bit of like a higher bump in that 250 to less than 500. And I really think that's because we've been moving some of those patients down through the dosing. So you're seeing them kind of move through. We are at 575, I believe, MME right now. So we just began that on October 1st. So we'll have another decrease here in January. But that's been moving through very smoothly as we kind of decrease our doses. So just a reminder, we started at 1,000, so we're almost half the way down, which is super exciting. It's taken a while, but we're making headway. When we look at the overall graph, and this is where I was talking, you can see that increase overall kind of from, last year into January, February, and we've started kind of on this just like slow, steady little increase kind of going. And really the new utilizers tends to will increase and then decrease a little bit. Our current utilizers has increased slightly. Kids have stayed about the same overall. So, and just as a reminder, the teal color at the bottom is the current utilizers that are adults. The cranberryish color is the new utilizers. And then the bluish purple color at the top is the under 18. So we're speculating a couple of things because we really don't have, I don't see anything in the data that's saying this is exactly why this is happening. But one, I think the pendulum has flipped a little bit back. So, everybody got really aggressive with limiting. And then it was kind of like, well, wait, we maybe got a little too aggressive and with the medical boards and every other group. So they kind of, I think has flipped a little bit back. So I think maybe we're seeing a little bit of that. The other thing I think that we might be seeing is we started a lot more elective surgeries after the end of kind of the health emergency with COVID. And so we've seen, that's where I think some of our new starts and a lot of the less than 90 people are falling, because that's where we're seeing our increase. So if you look, here's our less than 90 trend graph, and you can see it's drastically kind of increased since that same time frame. And so it's really in those people that are in what we think are maybe that shorter, lower term dosing. And so it may be reflective of either, again, doctors say, no, I can prescribe this for your pain and I'm going to prescribe it, or elective procedures that we're seeing. So that's kind of speculation on what we think at this point, but we're continuing to monitor to see if there's anything or trends otherwise that we're seeing aside from just we've kind of had this slow, steady increase. And the other doses, you can see, so the top one is the 90 to 120. That's why it's in the higher range. And really, we have such a small patient population in this group that even the movement of a couple people can drastically change how this graph looks. But our greater than 750 and 500 to 750 have really, have decreased over time and have stayed very low. And then you can see the increase in our 250 to 500, which I mentioned a little bit earlier. And that's kind of where we see some of the patients are, moving down their kind of decreased dosing line. So what I expect to see based on the population that we have is happening in this group. So nothing, super alarming. It's kind of what we would expect to see as we move through the dosing.
No, I think that's actually very accurate because I'm seeing a lot more prescribing. And in my experience, it's coming from the emergency room.
Interesting. Okay.
Yeah, I mean, I've weaned patients off and they're getting new supplies from the emergency rooms, and I'm getting pushback from the ER doctors about why my patients are showing up in the emergency rooms. And I think they've forgotten the lesson that the more they prescribe, the more they show up. Yeah.
That's interesting to know. I mean, we'll dig into that a little bit and see what we find. And maybe that's something that we need to have another intervention on or discussion about or something along those lines to see what's going on there.
Yeah, because I mean these patients they're getting it from the emergency room, they're also getting muscle relaxants at the same time. And they also have untreated sleep apnea. So they're all the major red flags that I think people are forgetting that came out of the big push to reduce utilization.
Okay, that's really good we'll take that back as something to look at and see if we see anything in particular around that. But that's interesting. Any other comments on or questions on this data? Any other new business? All right, I'm hearing none, so that takes us to public comment. So Dr. Shaw, I will let you start with those that are in the room, and then we can go to those that are on the phone.
Yes, we will show a little favoritism to the people who showed up. Neelish Nadkarni from AbbVie.
Good morning. Can you guys hear me okay? All right, okay. All right, I'll go ahead and start. Good morning, my name is Neelish Nadkarni from the MSPH, and I'm the Medical Outcomes and Science Liaison for AbbVie Medical Affairs. Thank you for the opportunity to speak today regarding upadacitinib, brand name Rinvoq, for which I'll refer to as UPA. UPA, an oral JAK inhibitor, consistently demonstrated efficacy across 7 indications and does so not only in DMARD patients, but in studies of 100% biofailure patients. Patients with UPA achieve rigorous treat-to-target goals of clinical remission in RA, clinical and steroid-free endoscopic remission, and histologic endoscopic mucosal improvement in UC. Patients with UPA have achieved minimal disease activity in psoriatic arthritis, ASDAS LDA and ankylosing spondylitis, and non-radiographic axial SpA, and EASY 100 in atopic derm. Focus today is now its 7th indication, Crohn's disease or CD. UPA is the first oral JAK inhibitor indicated for the treatment of adults with moderately to severely active Crohn's disease who have an inadequate response or intolerance to 1 or more TNF blockers. Limitations of use recommend that UPA is not for use in combo with other JAK inhibitors, biologics for CD, or potent immunosuppressants such as azathioprine and cyclosporine. UPA in adult CD has an induction dosage of 45 mg once daily for 12 weeks and maintenance dosage of 15 milligrams once daily. 30 milligrams once daily maintenance may be used for patients with refractory severe extensive disease. Onset of clinical response based on the CDAI score was observed as early as 2 weeks. UPA met both co-primary endpoints of clinical remission and endoscopic response at weeks 12 and 52. UPA carries the class box warning for serious infections, mortality, malignancy, MACE, and thrombosis, and is restricted to use after a TNF inhibitor and rheum and gastro indications. In contrast to what was observed with another JAK inhibitor, no safety signals for adverse events of interest such as BEs, DVTs, MACE, or malignancies. Common ADRs in CD include urea, anemia, pyrexia, acne, headache, and herpes zoster. UPA achieved superiority in head-to-head trials against 3 biologics with different MOAs, T-cell co-stimulation modulator in RA, TNF inhibitor in RA and PSA, and IL-4 inhibitor in AD. Along with depth and breadth and indication, UPA currently is the only oral option in Crohn's, has shown a rapid durable response, significant endoscopic control, and a favorable benefit-risk safety profile consistent with its rheum and derm indications. We respectfully request the committee to consider moving Rinvoq from non-preferred to preferred on the PDL. This is an abbreviated review of Rinvoq. Please refer to the PI for more information. Thank you for your time and happy to answer any questions you may have.
Any questions for Neelish?
So the request is to move it to preferred.
Yes. In summary, give patients access.
And you're telling us it has good efficacy.
What's that?
It has good efficacy.
Absolutely.
Okay. I know you're required to have that
Yeah.
preferred speech.
Balance of safety and efficacy, right? Yeah. But just happy to take any questions and afterwards as well. Happy to take any questions.
Okay.
Thank you.
Thank you very much for the time.
John Landis.
Alrighty, thank you guys for your time. My name is John Landis. I'm a pharmacist and medical science liaison with Brayburn. I appreciate the opportunity today to speak about Brixadi for the treatment of opioid use disorder. In 2017, the U.S. declared the opioid crisis a public health emergency, and in that year, there was a reported 40,000 deaths due to opioid overdose. Fast forward to today, the opioid crisis remains the only remaining national public health emergency. And just last year, the CDC reported over 80,000 deaths due to opioid overdose alone. This is double the number of opioid overdoses since that public health emergency was declared. Clearly, there's a need for more accessible treatment options. So today I'll speak about Brixadi, which is a long-acting subcutaneous injectable form of buprenorphine that was approved in May of 2023. It's unique in that it's available in both a weekly and a monthly injection. This was intended to meet the patient where they're at, provide them with another treatment option to help them initiate and sustain long-term recovery. It's unique in that, Brixadi is indicated for patients both new to treatment as well as those currently using oral buprenorphine. The way that it works is via a fluid crystal technology. This technology allows for a small volume to be injected into the subcutaneous space, forming a gel that is nearly unpalpable and allows for the steady release of buprenorphine. When compared to sublingual buprenorphine, Brixadi has demonstrated significant reductions in opioid use. Furthermore, a phase 3 trial that lasted 24 weeks included over 400 patients, 25% of which were exposed to fentanyl, found no overdoses in the Brixadi group and 5 overdoses in the sublingual buprenorphine group. Adverse events reported were injection site reactions, headache, constipation, and nausea, all of which were described as mild to moderate in nature. In closing, I'd like to advocate for the addition of Brixadi to preferred tier on formulary as soon as administratively possible. Appreciate your guys' time. Happy to answer any questions.
So your request is to move from non-preferred to preferred status.
Correct.
Are the proposed quantity limits appropriate?
I think so. So per our label, the weekly has a threshold of 5 to 9 days that can be administered. The monthly as early as day 21. So, I see that you have the monthly at 28 days. I think the opportunity to inject early at day 21 may be important for patients initiating treatment until they are, at a steady state. But the 28-day period is the recommended schedule.
That will follow the 85% rule too for early refill. So it's a 28-day plus an 85% rule and the 6-day plus the 85% rule, just as FYI.
Okay. Thank you.
Thanks.
All right, looks like we're to the phones. Let me get in the message box here and see who we've got. All right. So it looks like first on my list, I have Dr. Crystal Higgins Hall for the Epilepsy Foundation. Dr. Higgins Hall, are you on the phone? Oh, she does say, hold on, let me read her full message. She had a conflict at 9:30, I have no idea what time, 9:51. She just wanted to note her support of the Gold Card program for individuals living with epilepsy, and she had a conflict, so she wanted us to note that. Okay. So I think we're good there. Next up, I have Kalpesh Patel for Astellas Pharma on Veoza.
Yeah, good morning. I'm here.
Good morning. Go ahead.
Yeah, I'm Kalpesh Patel from Astellas, and I'm going to be talking about Veoza tablets, which are to be taken once daily with or without food. The burden of vasomotor symptoms is characterized by hot flashes in women undergoing menopausal transition, which is substantial, and it can be persistent for a median of 7.4 years with negative impact on quality of life. Veoza is a neurokinin 3 receptor antagonist indicated for the treatment of moderate to severe VMS symptoms, and it works by blocking the KNDy neurons to help modulate the thermoregulatory center. In two phase 3 trials that were conducted in about 1,000 women experiencing moderate to severe VMS symptoms, each of these trials demonstrated statistically significant and clinically meaningful reduction in the baseline of both the frequency and severity of moderate to severe VMS in patients who are taking Veoza 45 milligram tablet compared to placebo at week 4 and 12. Veoza is contraindicated in women who are known to have cirrhosis, severe renal impairment or end-stage renal disease, and who are taking concomitant CYP1A2 inhibitors. Also, looking at the warnings, there were elevations in the liver enzymes, 3 times the upper limit of normal in 2.3% of women taking Veoza versus 0.9% on placebo. Therefore, prior to the start of Veoza, liver enzymes need to be measured and then monitored at 3, 6, and 9 months thereafter. The most common adverse events were abdominal pain, diarrhea, insomnia, and liver enzyme elevation. In conclusion, we are asking to consider adding Veoza to the preferred drug list with open access, and I'll be happy to take any questions. Thank you.
Any questions for Dr. Patel? Thank you very much. Next up, I'm really sorry. I liked it better when Dr. Shaw had to read everybody's names and it wasn't me. I have Dr. Desiree, is it Crevecoeur McPhail? Or Dr. McPhail with Hikma Community Health for Clexado. All right, I'm not hearing, I'll come back and we'll see if you are there.
I think in her comment, she said, I will not need to present testimony today, so.
Oh, she said it later down. Thank you.
Yeah.
I just haven't scrolled down that far yet. Next up then, I have Dr. Mimo Odabi. I'm very sorry. Again,
That's okay.
thank you. I wish Dr. Shaw was reading names right now and not me. Fertiva, if you want to go ahead on Austedo XR.
Yes. Hello, my name is Mimada B. I'm with Teva's Field Value Evidence and Outcomes team. I'm here to provide information about Austedo XR extended release tablets. As you may already know, Austedo XR and Austedo are VMAT2 inhibitors indicated in adults for the treatment of chorea associated with Huntington's disease and tardive dyskinesia. The current marketed formulation of Austedo is administered BID twice a day. Austedo XR was developed to simplify the dosing schedule to once-a-day dosing. Austedo XR is delivered in a controlled manner for an extended period, thereby reducing fluctuations in plasma concentrations after drug administration. In addition, the patient's pill count is reduced due to the fewer tablets being consumed over 24 hours and across the entire titration period. Austedo XR is available as a 6, 12, and 24 milligram tablet strength and can be administered with or without food. A box warning does exist for the use of Austedo XR in patients with Huntington's disease for depression and suicidality. However, this warning is not associated with patients using Austedo XR for tardive dyskinesia. The recommended starting dose for Austedo XR is 12 milligrams once daily and may be increased at weekly intervals in the increments of 6 milligrams per day based on the reduction of chorea or tardive dyskinesia and tolerability, up to a maximum recommended daily dose of 48 milligrams. The 4-week titration kits can help patients titrate up appropriately. The efficacy of Austedo XR is based on a relative bioavailability study comparing Austedo XR tablets administered once daily and Austedo tablets administered twice daily. I just want to thank the committee for recommending that Austedo XR be moved to preferred status, as well as the titration kits. Thank you for your time, and I'm here to answer any additional questions.
Any other questions? All right, thank you very much. Next up, I have Bernadette Mamone with Neurelis for Valtoco.
Everybody, this is Kelly Murray from Neurelis. We had a later comment as well that we will yield back our time given the continued preferred status recommendation. Thank you.
Thank you. Appreciate it. And sorry to those on the phone, there's a lot of comments in the chat box, so I'm just going through in line. So if you yielded back time, if you just want to say that when you get on, that might be easier versus me trying to look back and forth with all the comments in here. I appreciate it. Next up, I have Hitan Patadia with Insight.
Yes. Hi, how you doing?
Great. Good, thank you. Whenever you're ready for Opzelura.
Awesome. Hi, hi everyone. My name is Ethan Patadia. I'm a pharmacist by training, and I work as a health outcomes liaison for Insight. I'm here today to discuss Opzelura. Opzelura is a topical JAK inhibitor with 2 FDA approved indications: mild to moderate atopic dermatitis for patients 12 years of age and older, and in non-segmental vitiligo in patients 12 years in age and older. For the full indication statement, please refer to our prescriber information. I'd like to focus today's conversation on atopic dermatitis. Atopic dermatitis is a chronic, highly pruritic, relapsing inflammatory skin disease, and the pathology of AD is mediated by inflammatory cytokines that perpetuate and exacerbate the itch-scratch cycle. The efficacy and safety of Opzelura for mild to moderate atopic dermatitis was evaluated in 2 phase 3 clinical trials. Patients randomly assigned twice daily use of Opzelura or vehicle for 8 weeks, and then continue on treatment in a 44-week extension period where Opzelura was applied as needed. Just to highlight a few key endpoints, a significantly greater proportion of patients who applied Opzelura achieved IGA treatment success, which is defined as IGA score of 0 or 1 with a greater than 2-point improvement from baseline. After a 44-week extension period where patients were transitioned to as-needed therapy, more than 70% of patients who had applied Opzelura achieved treatment success by week 52. Over 52 weeks, the affected BSA decreased by greater than 80% from an average of 10% BSA to an average of less than 2%. Opzelura does carry a black box warning for risk of serious infections, mortality, malignancy, MACE, and thrombosis. Additional warning and precautions are also included in the prescriber information. I'd like to highlight just one key additional analysis, which is a number needed to treat analysis that was calculated across the atopic dermatitis class. And in conclusion, I'd like to request that Opzelura be made available with limited steps to patients in Indiana. Thank you so much.
Any questions? All right, thank you. Next up, I have Dr. Warner Greer from the Bowen Center.
Hey, everybody. Thank you. This is Carolyn Warner Greer. I am an addiction psychiatrist at the Bowen Center and have a large population of patients that I treat for opioid use disorder. As was already stated by John earlier before, our opioid overdoses in this country are going to approach 100,000 this year. Unfortunately, we're kind of making the wrong direction despite our movement that we've done with prescription pain medication regulations. It is very rare that when I admit a patient at one of our treatment centers that they're actually using prescription pain medicine, but rather illicitly manufactured fentanyl. Long-acting injectable buprenorphine has been a game changer as far as our ability to help patients stay on medications before they achieve abstinence from fentanyl. Specifically, when it's taking a long-acting injectable buprenorphine product, even if they return to use, they will not have that lapse of protection until they can get another shot, versus sometimes people who, patients who are struggling with addiction who return to use will just simply stop taking sublingual buprenorphine and therefore will have no protection and also have difficulty due to the long-acting nature and the fentanyl of restarting buprenorphine. The number of adolescents I see, the number of patients who are living in controlled settings that are not allowed to self-administer medication and instead rely on long-acting injectable medications given in the office is growing exponentially. The prior authorization process is extremely cumbersome and unpredictable. We having used multiple mail order pharmacies that may or may not get a prescription continues to delay our ability to administer this life-saving medication. I would ask that both Brixadi and Sublocade remain preferred and that the stepwise fashion for prior authorizations be streamlined to indicate the imperative nature that these medications are started seamlessly. Thank you for your time, and I can answer any questions.
So this is Dr. Shaw. Are you noticing particular obstacles with accessing agents with the Medicaid program?
Yeah, I think the big thing is that it's just like I had a patient who traveled an hour and a half to get Sublocade. She's been on it for a year, and all of a sudden it needs a PA. She had to leave. She's been lost to follow up because she couldn't get it back again. So it's unpredictable. When patients, we have PAs denied all the time where they were approved 6 months earlier. I think one thing is to be noted that we've learned a lot about these medicines since Sublocade definitely and Brixadi in the future. One of the main things that people use these long-acting injectable buprenorphine products is to taper off of buprenorphine, meaning they may take it for a couple months and then no longer need medicines to treat opioid use, but we need to have the ability to restart that medicine if they have a return to use. The other thing is there are no less than 7 specialty pharmacies that each MCE wants us to use. Some of them don't take e-prescribing, some of them don't answer phones. The average time to get Sublocade, if the patient doesn't quit trying, is like 3 months now, because now Genoa is one that works great because they courier the medicine right to us, but only if Anthem and Anthem Medicaid let us use that. The rest of them are asking us to use pharmacies such as Cardia, Accredo, Walgreens Specialty. These are out of state. They don't answer phones. And I can speak for every provider in this call that we do not have the bandwidth to have people spending 2-3 hours trying to get a medication for somebody, especially one that is kind of critical in their well-being and staying alive.
So a couple of things for the fee-for-service benefit, we're any willing provider, so you can use whatever pharmacy you want in the fee-for-service. Obviously, managed care can dictate their own pharmacies, so we don't have a lot of say in that. As far as the PA process, Dr. Warner-Greer, I have my email up on the screen. If you would email me some examples, because nobody who's been on it long-term should be discontinued, so through PA or denied through PA. So if you have examples of that you can send to me, I can direct them appropriately. The PA that we've presented today is to help streamline the process, so we have very defined criteria across everybody, so we know exactly what we're looking at. So hopefully that will help, but I'd like to see examples so that we can try and see if there's something we can solve, and I'll let OMPP decide as far as the specialty pharmacies, et cetera. I'm not sure what a great solution is there.
Yeah, they're contractually allowed to set their networks. They have location requirements, but yeah, that is something they are allowed
through
to.
GMHA, we meet with the MCs and talk to them about this frequently, so there might be some room on that part.
Yeah.
I will tell you that I believe the PA process requires that someone fail multiple formulations of sublingual buprenorphine, including some that are not even indicated for opioid use disorder, such as a transbuccal or transmucosal patch or transdermal patch. Again, I don't do my own PAs, my team does, but I know that before that's been a reason for denial is that they only had sublingual buprenorphine / naloxone, and they didn't have like the mono product. Well, there's a lot of diversion with that mono product, and it's not really.
Can we, Amanda, can you reiterate what the changes we're making in the Sublocade?
And that criteria, so again, I'd like to see examples of that, because I know in our criteria for fee-for-service, we don't have the agents that are non-indicated for that. So if you have examples of that, we can definitely redirect. But as far as the criteria that we're looking at now, I'll use Sublocade as the example since it'll be moving to preferred, assuming the committee approves, is that they have to be 18 years of age or older based on their prescribing information, and then it's previous trial of one preferred oral formulation for opioid use for a minimum of 7 days. And as you know, for Sublocade, that's required anyway, of trial of an oral agent before you go to the injectable for at least the 7 days. And then prescriber has submitted medical rationale for use of Sublocade over the other oral formulations. We take all kinds of things for that, for rationale as far as diversion, compliance, all kinds of things that you can think of that we would look at for that. And then we've got the dosing in, and that they shouldn't be using it with Brixadi concurrently. So that's the criteria that we're moving to. So I think that should be.
And all the MCs will match that criteria.
Right.
Yeah, that'll be great, because I think that,
Yeah.
that you used not even give an indication for use if you didn't have the two failed agents. So I would also challenge, I didn't know that it was, I don't do a lot of adolescent care, but my colleagues do, that this is a key medication for the adolescent population, and that might be a big bite right now, but the worst population with self-administered medications would be a 15, 16, or 17-year-olds. But we ran into trouble because they didn't have Medicaid, but the patients I could think of. But that would be another topic, maybe with my friends from Wiley, to explore the utility of this for persons under the age of 18.
I can speak to that a little bit. A very common misconception with Medicaid is that we're only legally allowed to pay for FDA-approved indications. So in terms of pediatric use, the products would have to have an FDA approval for that age. That's the CMS requirements that we're under.
Gotcha. Thank you for your time, everyone. That was really helpful, and I'll email you those specific examples.
Yes, please. That would be great, and we'll address anything that we can for you.
Okay, I appreciate it. Have a good weekend, everybody.
Thank you. You as well. All right. Hopefully I'm not blocking my email for her anymore. I will go. So next we have Jenna Bowen with Marinus Pharmaceuticals on Ztalmy.
Hi, good morning. My name is Jenna Bowen, and I'm a medical science liaison at Marinus Pharmaceuticals, and it is my pleasure to provide testimony to the committee on Ztalmy, which was approved by the FDA on March 18, 2022, as the first and only indicated treatment for seizures associated with CDKL5 deficiency disorder, or CDD, in patients 2 years of age and older. Ztalmy is a positive allosteric modulator of GABA A receptors and is able to bind to a unique site present on both synaptic and extrasynaptic receptors, thereby enhancing GABAergic tone and providing a distinct mechanism of action from other anti-seizure therapies. CDD is a rare genetic infantile onset developmental epileptic encephalopathy caused by a mutation of the cyclin-dependent kinase like 5 or CDKL5 gene and has an incidence of approximately 1 in 40,000 live births, affecting females 4 times more often than males. Diagnosis of CDD is confirmed through genetic testing to determine the presence of a variant in the CDKL5 gene, and clinical presentation is characterized by early onset difficult to control seizures that is accompanied by severe developmental delay and intellectual disability. The safety and efficacy of Ztalmy was assessed in the Marigold study, a global double-blind placebo-controlled clinical trial evaluating the percent change in 28-day major motor seizure frequency in the double-blind phase relative to baseline. Enrolled participants with CDD had previously trialed and failed a median of 7 anti-seizure medications and had a baseline median 28-day major motor seizure frequency of 49 in the placebo group and 54 in the Ztalmy group. In this clinical trial of 101 children and young adults aged 2 to 19 years, Ztalmy significantly reduced the frequency of monthly major motor seizures associated with CDD by 31% compared to 7% with placebo. Ztalmy was well tolerated in the trial, with the most common adverse reactions including somnolence, pyrexia, salivary hypersecretion, and seasonal allergy. In closing, Ztalmy is the first and only FDA-approved treatment specifically for seizures associated with CDKL5 deficiency disorder in patients 2 years of age and older, and fills an unmet clinical need in the treatment of CDD-associated seizures, which are highly refractory to currently available anti-seizure medications. Thank you for your time.
Thank you. Any questions? Thank you very much. Next up, I have Dr. Girish Vitalper. I see you on camera, so I'm sorry if I'm butchering your name. And you're a director of allergy immunology at Riley and would like to speak about AviQ.
Sure. Hi, I'm Dr. Girish Vitalper. I'm the Director of Allergy and Immunology at Riley Hospital for Children at the IU School of Medicine. I'm a board-certified pediatrician and a board-certified specialist in allergy and immunology. We're all familiar with the food allergy epidemic and the fact that we're seeing increasing numbers of cases of children and adults having issues with anaphylaxis and being hospitalized. Children on Medicaid are unfortunately less likely to be receiving epinephrine before they come to the emergency room. And so it is vital that we provide them with sources of epinephrine that are easy to use and effective. AviQ has been around for over a decade and is a voice-guided epinephrine auto-injector technology. It is unique. It is the only one that has a 0.1 milligram dosing that can be used for children under 15 kilos of age. There are no other products on the market that have that 0.1 dosing. AviQ also comes with a 0.15 milligram dose and 0.3 milligram dose. Advantages of AviQ are that, number one, of course, the voice-activated technology. Number two, it is much less likely to cause accidental injection and injury. The needle retracts into the device after usage, and it is generally preferred by adolescents as well as caregivers. It is a smaller size and is much more easy to carry, and this is something that really seems to overcome a lot of family resistance in terms of epinephrine carriage and administration, and improves a lot of fear that is associated with using epinephrine with anaphylaxis. So I would request that you remove any barriers to access for AviQ prescriptions, especially for those who would need the 0.1 milligram dosing, which is for under 15 kilograms of weight. I'd be glad to answer any questions.
Any questions?
So AviQ is the only product that has this small dose. So you would,
yeah.
So you would ask access specifically for these individuals less than 15 kilograms in weight?
I would like access for at least the 0.1 milligram dosing for those under 15 kilos. It would be great to have, I mean, once people find that they have AviQ, they really like it, and having the 0.15 and 0.3 also be covered would be great, especially for sometimes children or family members who may have some intellectual challenges and cannot figure out or are able to use or read well and cannot use the other conventional epinephrine devices. So it'd be great if we could get all weight classes approved, but at least the 0.1 would be an important step.
Okay. All right. Thank you. That's helpful.
Thank you.
Thank you very much. Next up, I have Dr. Willis Lonzer with Amgen for Ravicti.
Good morning. Can you hear me?
Yes, we can. Good morning.
Excellent. Good morning. Willis Lonzer, Regional Medical Director for Amgen, and I'm here to discuss with you in this public testimony Ravicti. UCDs, or urea cycle disorders, are rare diseases impacting 1 in 35,000 live births in the U.S. The robust clinical trial programs championed by the patient community were designed to address the exact issues of compliance and adherence. Ravicti is nearly odorless and nearly tasteless, and with no time limitation placed on ingestion of the medication, whereas the taste mask versions of sodium phenylbutyrate have very limited time frame during which the taste is actually masked. In addition, Ravicti can be administered via G-tube, while taste mask versions cannot. Moreover, Ravicti is the only approved medicine that can provide treatment across the entire lifespan, regardless of age or weight. It is approved for all subtypes of UCDs except for NAGs. Taste mask versions are only approved for 3 UCD types. In Indiana, Indiana has 4 UCD patients with primary medical coverage who take Ravicti. The clinical manifestations that have been shown to be significantly reduced by Ravicti are more devastating for newborns and pediatric patients. Notably, 3 of the patients on Ravicti in Indiana are under 18 years of age. The 1 adult patient has been on therapy for 10 years. Due to the grave risks involved with switching stable UCD patients to a new therapy, we ask respectfully the committee that you provide a strong consideration in allowing existing stable Ravicti patients to maintain access to their current therapy and also to maintain current criteria for patients to access Ravicti. Thank you for your time.
Okay, so this is Dr. Shaw. I have to admit, I'm not familiar with the drug you're speaking about. How do you spell it and which class does it belong to?
This drug is Ravicti, Ravicti. It is in the urea cycle disorders class.
Oh, okay.
And it is the base of it is a glycerol phenylbutyrate. That's the formulation versus a sodium sulfate. This is grouped in the class of inborn errors of metabolism.
Okay. Okay, so you're advocating for the current 5 users of that in Indiana?
Yes, 4 users.
4 users, okay.
There is reauthorization criteria, but it does look for trial of another preferred agent first as well, if they've had a previous trial or prescriber documentation as to why they're continuing. Any other questions for Dr. Lunzer?
Thank you, Dr. Lunzer.
Thank you.
Thank you. Thank you very much.
Next up, we have Mark Golick with Neurocrine Biosciences for Ingrezza.
Hi, good morning. Can you hear me okay?
Yes, we can. Good morning.
Great, thank you. Good morning. So my name is Mark Golick. I'm a PharmD, the Associate Director for the Managed Care Liaison Team at Neurocrine. And thanks for the opportunity to provide some testimony in consideration of the fact that the committee has now included our newest indication for tardive dyskinesia, for Huntington's disease, along with tardive dyskinesia for Ingrezza. I'm going to turn my time back in and ask if there are any questions.
Any questions? All right, thank you very much. Appreciate it.
Okay. Thank you very much. Have a good day.
Next up, we have Dr. Collins around the Gold Card program. Dr. Collins. He may no longer be here, but he said in his message, in appreciation of the Gold Card program, he would like to make a comment. So we'll go with his appreciation for the comment. All right, and then looks like lastly, I had a note in the chat that Dr. Jason Go is here from Amgen for Amgevita that would like to provide comment that didn't get to sign up.
Sometimes the most obvious details are overlooked. I'm sorry for the silence.
No, you're fine.
So thank you again. Good morning, everybody. My name is Jason Go. I'm a medical science liaison working with Amgen Medical Affairs. I'm here to provide information for Amgevita in support of Amgen's request that the committee deem Amgevita at parity with its reference product Humira as a preferred agent in the state-targeted immunomodulator PA criteria. Amgevita is the first FDA-approved biosimilar for Humira, adalimumab, a monoclonal antibody that binds to and blocks the activity of tumor necrosis factor. Amgevita is highly similar to Humira with no clinically meaningful differences in safety or efficacy, based on extensive analytical and non-analytical studies, clinical pharmacology, and comparative clinical studies. Comparative clinical studies to Humira were completed in patients with moderate to severe rheumatoid arthritis and moderate to severe plaque psoriasis. In both of these studies, the efficacy endpoints being an ACR of 20 and PASI were within predefined equivalence margins, confirming that the treatments were equivalent. The most frequent adverse events in these trials were nasopharyngitis, headache, arthralgia, cough, upper respiratory tract infections, psoriasis, diarrhea, and back pain. Based on the totality of evidence, Amjevita is FDA approved for the treatment of psoriatic arthritis, moderate to severe polyarticular juvenile idiopathic arthritis in children 2 years of age and older, ankylosing spondylitis in adults, moderate to severe Crohn's disease in adults and children 6 years of age and older, moderate to severe ulcerative colitis in adults, and the treatment of moderate to severe hidradenitis suppurativa in adults. Amjevita is supplied as a latex-free pre-filled syringe and SureClick auto-injector for subcutaneous injection, and the 20 milligram and 40 milligram dose formulations are both citrate-free. Amgen kindly requests the committee to provide access to Amjevita and deem it as a preferred product on the state PDL. Thank you again for your time, and I can answer any questions related to Amjevita and can provide the full prescribing information. Thank you.
Any questions? Thank you very much.
Thank you. Thank you.
Any other public comment that we may have missed that wasn't in the chat box? You can raise your hand if you're online. You can raise your hand if you're in the room. Or shoot a message. Oh, Dr. Collins is here. Dr. Collins, please go ahead and proceed.
Hi, my name is Dr. Collins. Can you hear me?
Yes, we can.
Yeah, I'm calling on behalf of sorry, I'm losing my voice here. The Gold Card program. Just wanted to add my appreciation for you guys approving the program. As a neurologist who treats a lot of patients with intractable epilepsy, it has been a major benefit for us in terms of trying to find the appropriate therapy to help manage these folks who don't have a clear path to therapy to help resolve their seizure activity. One of the things that's been beneficial, and from my perspective, is that it allows me to get to more efficacious therapy more quickly and more aggressively, simply because of the ability to be able to change medications in patients who have been tried on a number of medications over the years with varying results. So it has made a huge difference in terms of reducing the frequency, severity, hospitalizations, and injuries associated with these patients. In addition, we are very concerned about SUDEP, and this, I think, has been a major benefit in that regard. And I definitely wanted to thank the program for allowing us to do that, and would hope to continue to do that in future to the benefit of our patients. And be happy to take any questions.
Thank you, Dr. Collins. Any questions?
Thank you.
I don't think we have any. Thank you.
Thanks.
Any other public comment? I don't see anybody else hand raised.
We had that one person who didn't, or did she?
She gave back her time. I did find that later on in the. Okay, I think that takes us to any other business.
Which I don't think there are any, so I will go ahead and call to close the first session of the T committee for today. We'll move on to executive session.
Yeah, I would ask for those that are in the room that are not participating in the executive session. We're already 25 minutes behind, so not to say get out quickly, but please get out quickly so that we can get started. And so hopefully we'll start on time at 11 for the next open session. If we're not ready yet, we'll let you know when we start. For those on the phone, we'll join over to the executive session on the phone. And for those who want to come back to the open session, we'll come back to this same meeting. And if we're not there when you come there, we're running a little behind, and we'll get there as soon as we can. Thanks, everybody.